Hello, my name is Morgan Lima. I am a registered nurse and have partnered with Picmonic to bring you this video on HIV. You can find me on Instagram at the Teachable Nurse or at my website at www.theteachablenurse.com. This is the second video in a 3-part series, so if you have not watched the first video, I recommend going back and doing so since these lessons build on each other. And the first video discusses the foundational knowledge you need for understanding HIV and how it works against the body's immune system. In this video, we're going to dive into HIV treatment and the different classes of medications available to suppress the virus. So let's get into it. First, I want to review what a retrovirus is, because that's really important. So HIV is a retrovirus, meaning it inserts copies of its DNA genome into the DNA of the cell it invades, therefore changing the host's cell's DNA and its genome. So HIV is treated with a class of medications called antiretrovirals. Remember, HIV cannot be cured, but antiretrovirals suppress the virus's replication process, therefore preventing uncontrolled viral replication. The different classes of antiretrovirals are nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, integrase inhibitors, protease inhibitors, and entry inhibitors. Notice how most classes of drugs have the word inhibitor after the name of a specific enzyme found in HIV. This is important as we walk through how each class targets the different parts of the life cycle and why it's important to know what each HIV enzyme is responsible for. Let's start with nucleoside reverse transcriptase inhibitors, or NNRTIs. These work to stop the third step of the HIV life cycle by blocking the conversion of HIV RNA to HIV DNA. They are prodrugs, meaning that outside the body, they're inactive, but once they're introduced to the body, they're activated by enzymes and metabolized throughout the body, serving their purpose. Once NNRTIs become active in the body, they compete with naturally occurring nucleotides to bind to reverse transcriptase. Essentially, they swoop in before nucleotides can, therefore terminating the DNA chain of HIV. This breaks the virus's life cycle. A few examples of NNRTIs used in the treatment of HIV include tenofovir alafenamide and tenofovir disoproxil fumarate, which we will touch on later when discussing PrEP and PEP. Emtricitabine and limivudine are 2 NNRTIs that are common in most ART combinations. Remember, ART is just a shortened way of saying antiretroviral therapy. The very first antiretroviral, AZT, was actually an NNRTI, and that was actually used as what's called monotherapy for a really long time. But they soon learned that you can't just use one drug or one class to stop one part of the HIV life cycle in order to suppress it. Specific adverse effects associated with NNRTIs include dyslipidemia, adiposity, and insulin resistance, among some others. Insulin resistance can occur secondary to damage to cells' mitochondria from the NNRTIs. So some people who begin antiretroviral therapy experience a sudden increase in weight. And when people are underweight to begin with, which is sometimes common with people who are newly diagnosed with HIV, it's not a surprising occurrence for when they start their antiretroviral therapies, they suddenly gain that healthy weight back. However, once the metabolism kind of evens out and these metabolic changes continue, this can lead to things like obesity and insulin resistance and mitochondrial damage even, and that can be really concerning. Patients should establish a healthy diet and exercise routines in order to help prevent some of these conditions, and their providers may also recommend that they see a dietitian. So now let's move on to NNRTIs. So NNRTIs, or non-nucleoside reverse transcriptase inhibitors, are similar to NNRTIs in that they block the conversion of HIV RNA to HIV DNA. They do this by binding to reverse transcriptase and inactivate its attachment site. However, they differ from NNRTIs because they do not break the DNA chains. NNRTIs have a high resistance profile, and so therefore if someone begins taking this medication class, they must continue taking their drugs consistently, because if they have an interruption in their treatment, let's say they stop taking their medications for a whole month, then they have a really high chance of becoming resistant to the entire drug class. So if people are prescribed medications from this class, it's extra important that they make sure they take it every day at the same time. Some people's genes have mutations that make them resistant to certain drug classes to begin with, even before they start medications. And one of these mutations, called K103, makes someone resistant to all NNRTIs. Efavirenz, nevirapine, etravirine, rilpivirine, and doravirine are all examples of NNRTIs. Doravirine is one of the newer ones that has been prescribed for treating HIV. And just like with all HIV medications, NNRTIs are prescribed in conjunction with other classes of HIV medications, thereby effectively preventing HIV replication. So moving on to integrase strand transfer inhibitors, or INSTIs. These block the insertion of HIV DNA into the CD4 cell DNA. Remember that the integrase's job as one of HIV's enzymes is to help integrate the provirus into the CD4 cell's DNA. And when INSTIs prevent this part of the life cycle, HIV can't become active. It just remains latent. And this class is actually a newer class of HIV medication and commonly used in people who are newly diagnosed today. Raltegravir, dolutegravir, elvitegravir, and bictegravir are all examples of INSTIs. This class and what they do is easy to remember because their names all end in gravir. A way I remember how INSTIs stop HIV from replicating is to think that they aggravate, or gravir, the HIV DNA because they prevent them from entering the CD4 cell's DNA, and that makes them really aggravated. A serious adverse reaction in someone taking INSTIs is elevated creatinine kinase. Therefore, people who have a risk of myopathy or rhabdomyolysis should watch carefully for signs of these diseases if they start taking this class. One benefit of taking INSTIs is that there are very few genetic mutations associated with resistance to integrase inhibitors. So that's one of the reasons it's commonly prescribed to people who are newly diagnosed, because there is a very low chance that that person's going to be resistant to any of the medications from this class. Protease inhibitors, or PIs, are different from the rest of the classes we've talked about so far in that they block protease from helping non-infectious HIV become infectious HIV. Protease is another enzyme in HIV, and enzymes have these active sites, and when those sites are rendered inactive, they simply can't do their job. Since protease's job as an enzyme is to break up the long protein chains in the non-infectious virus, creating mature infectious virus. By inhibiting this enzyme, protease inhibitors prevent this part of the HIV replication cycle. Examples of PIs include atazanavir, darunavir, idinavir, lopinavir, ritonavir, and nelfinavir. PIs typically end in the suffix avir. To remember this, I think of protease veering out of the way once it sees a protease inhibitor approaching, and therefore it's unable to help that non-infectious HIV become infectious. PIs also must be used along with other classes in order to stop HIV at the different steps. A severe adverse reaction to be on the lookout for with protease inhibitors include elevated liver enzymes. More common effects of PIs include metabolic changes such as adiposity and lipodystrophy. And as we spoke about before, with adiposity and things like that, these can lead to things like insulin resistance. And so it really is something to be on the lookout for in people who start these medications. I listed all of the enzyme inhibitors first because this last drug class I'm going to talk about, entry inhibitors, are less commonly used today when prescribing ART. Entry inhibitors prevent the attachment and fusion steps in the HIV life cycle. Remember that with attachment, GP120 uses both the CD4 receptor and the chemokine receptors CCR5 and CXR4 to gain entry into the cell. The two common entry inhibitors used in the past were called enfuviratide and maraviroc. These are no longer commonly prescribed as part of an ART regimen because there are more effective medications with less side effects that have come out in recent years that do a better job of preventing the virus from replicating. However, you may still see patients who are on maraviroc just because it's something that they were prescribed when they were first diagnosed and it works for them. Now let's transition from talking about HIV treatment to discussing HIV prevention. PrEP and PEP are known for preventing HIV infection after an exposure. PrEP stands for pre-exposure prophylaxis. It's a great acronym, really, because it basically means to be prepared. PrEP is another name to prevent HIV transmission, and the two FDA-approved medications to be used as PrEP are Truvada and Descovy. These are both one pill, once a day medications that people must take consistently in order to ensure their efficacy. A person must take their medication, try to at the same time every day in order for it to actually work. And so Truvada is a combination of two antiretrovirals, emtricitabine and tenofovir disoproxil fumarate, commonly shortened to TDF. So when I talk about TDF now, you know what I'm talking about. Emtricitabine is a nucleoside reverse transcriptase inhibitor, and TDF is also an NRTI. And so you might be thinking, well, wait, I thought you couldn't just treat HIV or prevent HIV with one class. The reason these two can come from the same class and still prevent HIV is because the person taking Truvada is not yet infected with the virus. Therefore, there is none circulating the body needing its life cycle to be interrupted. Rather, if the person is exposed to HIV, the two medications in this class are sufficient to stop the virus from entering the CD4 cell in the first place, thereby preventing HIV infection. Descovy is similar to Truvada in that it also contains emtricitabine, but the other medication in this one pill formulation is called tenofovir alafenamide, more commonly known as TAF. TAF is a newer version of TDF, and the main difference is that it is known to less likely cause side effects associated with TDF. Some of those side effects associated with TDF include bone density loss and worsening kidney function in those who are at a greater risk for such problems. Emtricitabine and TAF are also both NRTIs and work the same way Truvada does to prevent HIV infection after an exposure. So we've talked about PrEP. PEP, PEP, on the other hand, is post-exposure prophylaxis. This is used when someone may have had an exposure to bodily fluids that have HIV in it, or if, let's say, a healthcare worker gets stuck by a used needle, they may go on PEP to prevent HIV. PEP typically has 3 medications in it, similar to a full ART regimen. And this is because the person needing PEP does not already have the defense of PrEP in their body. So they haven't been taking an antiretroviral therapy every day for months. They don't have any of that in their system, and they may have had an exposure. And so this is kind of an emergency use situation. They're therefore more at risk for HIV successfully entering the CD4 cell at this point in time and rapidly replicating. And that's why PEP has 3 medications in it, typically from 2 different drug classes. And so I've talked a lot about how different classes of HIV medications form an ART regimen. So let's talk about what an ART regimen is and how doctors or prescribers decide which medications to put together to create an effective ART regimen. ART regimens must have medications from at least 2 different classes. Many ART regimens are already available as one pill. An example of this is a pill called Biktarvy. Biktarvy is a 1-pill, once-a-day regimen containing bictegravir, which remember is an integrase inhibitor because it aggravates, the tenofovir alafenamide, also known as TAF, and emtricitabine, which, to make matters even more confusing, is also known as 3TC. And so remember, TAF and 3TC are both NRTIs. So 2 classes, 3 medications, all in one pill. And because the different classes of ART stop HIV at different points in the life cycle, it's important to ensure that patients have all of their medications filled at the same time, because not all medications are one pill once a day. So an example of this would be a patient receiving doravirine, which is an NNRTI, and TAF and 3TC, which are both NRTIs. And this does not exist in a one pill formulation. You have to get the doravirine, and then you get the TAF and 3TC in its own pill. So since this is a 2-pill regimen, when refilling their prescription, patients need to be sure that both medications are filled together. And this is something that's important at the nurse level, the prescriber level, and the pharmacy level, as well as the patient should always know that they need to take their pills together. If a patient for some reason wasn't able to get their doravirine, but they had their TAF and 3TC, it's better not to take half of their medication combination and just wait until they have that other medication. It's better not to take half of a regimen and just go on and miss it, because if you're just taking half that regimen, you are more likely to become resistant to the other half of that. And so it's just best to wait until you have both medications. You miss a couple days of your regimen, as long as you're otherwise consistently taking it, it's not going to be harmful. Some regimens are taken once a day and others are taken twice a day. And so as you can see, ART regimens are not a one-size-fits-all situation. Prescribers have to be really careful to make sure they don't prescribe a regimen that the patient may be resistant to. Remember, we were talking about those mutations. So to determine if a patient is resistant to a certain class of HIV medications, after they are diagnosed with HIV, they perform a blood test called a genotype. A genotype tells the doctors or prescribers what classes, if any, the patient is resistant to by identifying genetic mutations that the patient has. Certain genetic mutations, like the K103 we talked about, align with a known resistance to certain drug classes like NNRTIs. Therefore, the prescriber would recommend an ART regimen that didn't include any NNRTIs. On the topic of safe ART regimens, did you know that women living with HIV can take a safe ART regimen while pregnant, preventing transmission of HIV to their baby? There are several safe ART regimens in pregnancy, and women with HIV who are receiving treatment can safely get pregnant and birth their child while preventing perinatal transmission. Now I'm going to mention 2 very important lab values associated with HIV and ART. These are blood tests known as a viral load and a CD4 count. Viral load refers to the number of copies per milliliter of HIV virus in a person's bloodstream. Many labs have different thresholds, and some labs can detect as low as 20 copies, meaning that if a person is undetectable, then their lab would read less than 20. However, the CDC officially defines undetectable as less than 200 copies. CD4 cells, as we've discussed, are also known as helper T cells. These are the white blood cells that are a part of the entire immune system, meaning they fight off infections. And in people living with HIV, CD4 cell count is a really good indicator of the progression of the virus, as well as how strong a person's immune system is. A good CD4 count is greater than 400. A CD4 count of 200 or lower means the person's HIV has progressed to AIDS. Antiretrovirals lower the level of the virus to a number so low that it is not detected on standard lab tests. And like we said before, this is called undetectable. And this is the goal of antiretroviral therapy. So you may be wondering, if HIV medication is so effective at suppressing the virus to the point where it's not detectable on lab tests, why can't the person be considered cured of HIV? And the reason behind this is because of something called the HIV reservoir. So even though the virus is suppressed, HIV is still present. Remember, it's in that latent state. And as long as a person living with HIV continues taking their medication, the virus will remain this way. The reservoir refers to the group of CD4 cells, which exist throughout the entire body as a part of the immune system. Remember, not just the blood. refers to that group of CD4 cells that are still infected with the latent HIV virus, but not actively reproducing the virus. And these are found not only in blood, like I said, but adipose tissue, cerebral spinal fluid, and any place in the body where CD4 cells may be present. Therefore, as of right now, it is impossible to target all of the latent HIV virus to consider a patient cured. Thank you for joining me for this lesson, and now you may move on to the third and final video of this series on HIV, where we will discuss complications that can co-occur with HIV.